People can go and log on to the WHO website and they can see this. You can see, here, this is all ages, and you can see from that one, depression is in blue. Blue means it's getting more, it's not getting less. And the size of the box tells you how big it is and how relevant, and also the more it goes higher, the more it's more relevant. And that is over the past 15 years is getting more. If you look at what is for me is the important age, when you talk about adult age, the people who are working, the people who are building their families, people who are building the nation, And when we look at that, we see out of all diseases, depression is on the rise. Unfortunately, drugs is as well, and diabetes, but you can see how big a box depression is, and that's for, all ages imposing, burden of the disease, and again, with the next one, how much is causing disability. So depression is here. And this is, I'm talking about UAE data, it's not like anywhere else. So we have to take it very seriously. And when we talk about depression, it is, yes, emotional, but it's more than emotional. We talk about feeling sad, you're feeling irritable, you don't enjoy things, which is, I think, is a common thing. And you say, yes, people get that. But when we have all those symptoms together, and we have hopelessness, and then we feel suicidal, and yes, I say suicidal, even though this is a word that we don't like to talk about. People would say, oh no, we don't have that. And actually, when I first moved to the country here 4 years ago, when I asked people if they are suicidal, one of the kind of comments that I'll get, astaghfirullah, as if, why am I asking this? But I started, somebody, I forgot who told me, let's ask it this way. If it's not haram, do you think about killing yourself? And I'm very surprised how many people would tell me yes. But then, I would not do it. And, and of course, religion is protective. But it is like any disease, like cancer. If you die from cancer, it's not because you've done anything wrong. And the same thing with suicide. You're getting those thoughts. You don't want them. They're stronger than you. It's not, how faithful you are or how good you are. It is affecting us, and we have to ask about that. But so this is more of the emotional bit. But if we look about the other bit, you feel tired, you feel headaches, and you see in this region there's a lot of somatic symptoms like, headaches, problem with sleep, with appetite, stomach pain, chest pain. So there's a lot of physical symptoms as well. But the new one, and this is why I said we're going to talk about cognition. We talk about cognition now more. We find it more in schizophrenia. We talk in schizophrenia research. We find it more in, depression and anxiety research. Because I think this is what is very important, because nowadays we want to function better. And we notice that people have problem with attention, people have problem with short-term memory, their kind of sharpness. So you feel like, okay, he's not that sharp. And that's very key, because that's what makes us functioning to the best in our jobs and, affect us in our decision-making and judgment. So depression has a huge impact on that, and this is very key. And, talking more about the cognitive symptoms, this is one of the most super common symptoms that we have in psychiatry, because, we talk about, almost all patients. When we talk 94%, that's almost other than 1 or 2 who did not report it. But interesting enough, when we treat depression, we still have the main deficit in cognition. We find them, yes, feeling better, not sad, able to sleep, able to eat in earlier treatment, but still, when what we call remission in the normal way, we struggle, and we still have almost half of the people, they do have some symptoms of cognitive impairment when they are in remission. And that would affect them to say, okay, difficulty to continue with a job, loss of productivity, and problem with irritability and all of that. So it is very important not to underestimate how much our cognition plays an impact on our day-to-day life. And this is again when we try to look about depressive symptoms. When we go into, we say, okay, alhamdulillah, they're just clean from everything, no more depression. We kind of find a lot of cognitive problems that are persistent with symptoms, even when we get to remission. So this is one of the key things that, we're learning more about day after day. So what are people's expectations? I've done gallbladder surgery back in 2006. So when I did the gallbladder surgery, from my medical school when I trained in Syria, I remember it used to be kind of, or you see people around you, you go into hospital, you leave after, a day or two, you stay in the house a week or 2 weeks, and, you have to have very restrictive diet and what you eat. I remember I've done it, I woke up, in the room, and then I was lucky, even though it was NHS, I had a chef coming to ask me, what do you want to have for lunch? And I said, am I allowed to eat? I said, oh yes. Whatever you want. I had actually gnocchi with Philadelphia sauce at the time. But what expectation is, you leave. I left the hospital in the afternoon. He said, you can go back to work tomorrow, but I'm going to give you a week leave. Of course, I didn't say no at the time. I was a registrar. But this is different from our expectation before. And I would, our patient expect not just to get better. I want to be as good as I was before, and I want that tomorrow. So we are changing in what we demand from doctors. We are changing in our expectation. And before, our expectation, yes, I'm sad, I'm suicidal, I'm depressed, I want to feel better. But now, no, I need to go back to where I am. I have a patient who's a CEO in a bank. He just wants to be even better. He wants to even, go even sharper than before. And I'm sure that's in every specialty. Patient, usually when they are in acute, they want to get better. But within a week, they would ask you to, okay, I want to be 100%. And that's how things are changing with time. So, talking about Parkinson, so that's one of the first focus I want to say. Is it common to find depression in Parkinson? One of the studies, they say about 30 to 50%. So, anybody deals with Parkinson? Do we ask about depression? Seriously? Every time? Okay. Do you find half of your patient with depression?
No, it's a little bit different, I believe at least, the patient with Parkinson, because of the hypomania and a little bit this slowness, even if they, even they looks depressed, even without talking. So I think that is also maybe contribute to this 50%. So it is dependent on the stage. If it is initially maybe less, and if it goes maybe with the severity of the disease.
Okay, let's keep that thought in mind. So I'll give you a few slides and we'll have another discussion about that. So it is, we know, Parkinson is kind of common. I don't need to tell you that, a lot about that. But yes, those are the main symptoms. So we have the cognition and we have the mood as well. So mood symptoms, usually depression, anxiety. And actually, it is 40 to 50% in a lot of studies. And in one review, they talk about what you were talking about. Dysthymia, 22%. So dysthymia is you're constantly for 2 years low in mood, but not very severe. Minor depression and major depression. And interesting enough, if you put all these numbers, actually, this is, if I'm going to go with that, I'm going almost to 80%. So, but if I'm going to talk about like depression, when we say about the levels there, so at least significant major depression in quarter, but I wouldn't, forget the 36%, which is a milder depression there. And, the depression doesn't only impact the patient, it impacts everybody around them. The disease itself impacts the patient, but the depression impacts the whole family as well. And the onset of depressive symptoms and their natural history not always go along with motor disturbance, Sometimes we might have our first symptoms, at least some of the research suggests, are depression before we find the Parkinson's syndrome later on. So, is it what's causing what? That's, we don't know what's the underlying mechanism of depression. We don't know there. But when we talk about treatment, we have a lot of treatments there. And, this is very important. When we talk about, yes, do I believe there's depression? And, yes, everybody said, yes, there's a lot. We're starting to kind of to say, well, is it depression? Is it not? Actually, it is depression. When it is depression, when I assess it as depression, and I think it is depression, I need to treat it. And, they did network meta-analysis there, and they tried to see what kind of medications that works there. And, all the people who work in research, the annoying bit is when you have so many studies and something touches the line. And unfortunately, it touched the line. So that's what tells us, is not the most amazing news there. But what do we do when we try to look at different medication? We still find some positives there about antidepressant. And one of the most bigger systematic reviews we looked at there, and it did favor the use of antidepressant more than all interventions. So antidepressant in this one, it was quite helpful when I put them all together. But if you look at all those studies, so many of them touching the line, which is not the best outcome you would want. And that maybe make it why it is the most complex to treat depression with Parkinson's there. So, what side effects? Because obviously if I'm going to treat somebody with Parkinson, I'm always worried about side effects. And this is kind of a list of what stop you from treating patients with an antidepressant. Usually, we talk about bradykinesia. Actually, it is not very common. And that's usually what the neurologist will be worried about when they treat that. Cardiac side effects, it is with tricyclic, but we rarely use tricyclic other than when some of you guys use triptizol with a very low dose, which is not an antidepressant. So it is not that common. Sedation, is mainly with some medication like trazodone, which is hardly available and is not very strong antidepressant. And anticholinergic, it is also with tricyclic. So there's nothing to scare us from treating depression, when we use, antidepressant. And that is very important, because when I say I'm going to go back to this, I know we all believe in depression, and it is there. But when we really have to go all the way to treat it, you see hardly,